virtual meeting, and I have no disclosures. My task today is to talk about the pitfalls in the assessment of valvular disease. My plan is to focus on some of the common ones that we encounter on a regular basis. Echo is essential in the assessment of valvular heart disease. Not only can we learn the type of valvular dysfunction, we also gain insight into the etiology, mechanism, and severity of the dysfunction. Furthermore, a good understanding of intracardiac hemodynamics, such as filling pressures and pulmonary artery pressures, can frequently be obtained. The severity and clinical significance of a valvular dysfunction should not be based on a single measure. Indeed, the strength for echo is that multiple anatomic and functional aspects can be assessed in the same setting. But we do need to be aware of the limitations and variabilities inherent in any of these measures. We should include both qualitative and quantitative variables and bear in mind that our assessment should be interpreted in the context of the patient's hemodynamic during the study. Let's look at the case of this 69-year-old woman who had a myocardial infarction in 2018. She went on to have stent to her left circumflex artery, but ended up with a left ejection fraction of 37%. She has become progressively short of breath for the last 2 days prior to presentation. Her blood pressure and heart rate are shown on this slide. The poststernal images confirm left ventricular dysfunction. The posterior wall is thin out and akinetic. There was restriction of the posterior mitral leaflet. Moderate mitral regurgitation was present, which was directed anteriorly. These images show the right ventricular inflow view and the view of the pulmonary artery. At least moderate tricuspid regurgitation is seen, and the spectral Doppler showed that the peak tricuspid valve velocity was about 3 meters per second. Mild pulmonary regurgitation was also present, with early diastolic velocity about 2.8 meters per second and end diastolic velocity 2 meters per second. What do you think her pulmonary artery systolic pressure would be, assuming a right atrial pressure of 8 millimeter mercury? Was it 36, 44, 57, or 65? This was a study that I was involved in during my fellowship long time ago. We performed Doppler study to assess the tricuspid regurgitation velocity in the cath lab and compare the gradient from RV to RA gradient by Doppler with cath measurements. We showed that there was very tight correlation between these two measurements with an R value of 0.96. But there are many other studies that did not show such a tight correlation. And there are several reasons for that. Firstly, in many of the studies, the Doppler assessment and cath assessment were not done simultaneously as it was done in our study. And we know that the pulmonary artery pressure can vary quite considerably from hour to hour. The more important reason for the poor correlation is using suboptimal tricuspid regurgitation signals. This is one example. You can see that the envelopes of the tricuspid regurgitation signal are not well displayed, and there is considerably difference of the peak velocity from beat to beat. And yet, very often, the pulmonary artery systolic pressure was based on such suboptimal signals. Let's return to our patient. Although the tricuspid regurgitation envelope is quite complete, we note that the early pulmonic regurgitation velocity was 2.8 meters per second, which gave a mean PA pressure of 39 mmHg, which would be not consistent with a PASP of 44 mmHg. So what would be the reason for this discordance? We should not interrogate tricuspid regurgitation just from one window. When we examine the tricuspid regurgitation from other windows, we found that the velocity was actually considerably higher. You can see that the velocity is about 3.2 meters per second from the short axis view and 3.8 meters per second from the apical window, giving a PASP of 65 mmHg, highlighting the importance of good alignment of the velocity jet with the Doppler beam. The importance of interrogating multiple windows to ensure good alignment of the velocity jet with the Doppler beam is well known, particularly in the assessment of aortic stenosis. In this example, there's a good spectral envelope of aortic stenosis from the apex, and most of us would probably be happy to accept that as the aortic velocity. But from the right sternal border, you can see that the peak velocity was clearly much higher, again emphasizing the importance of using multiple windows. Our case shows the importance of getting robust primary data from 2D and Doppler. The primary data are the basic measurements that are then used to calculate other indices. For 2D, we are talking about LV dimensions and wall thicknesses, from which we can derive LV volume, LV mass, and ejection fraction. For Doppler, we are talking about the peak velocity and the duration of the velocity signal. To assess valvular dysfunction, multiple windows should be used, and good Doppler alignment with the velocity jet is essential. In order to achieve that, non-imaging probes should be readily used, especially in patients with aortic stenosis. The next case was a 79-year-old woman with hypertension and hyperlipidemia. She had no diabetes or stroke. She had a bypass surgery in 2012, and unfortunately, she had developed recurrent angina. A recent coronary angiogram showed that the grafts were patent, but she had severe native disease. Her blood pressure during the echo study was shown here. She was clearly hypertensive with a blood pressure of 202/66 during the echo study. The peristernal images showed normal left ventricular size and function. No apparent regional wall motion similarities were identified. The aortic valve showed sclerotic changes. There was also mitral annular calcification. The apical images confirmed normal left ventricle size and function. There was mild mitral regurgitation and tricuspid regurgitation. No aortic regurgitation was detected. Doppler interrogation included pulse wave interrogation of the left ventricular tract shown on your top left, CW interrogation of the transaortic velocity shown on your top right, CW interrogation from the suprasternal window in your lower left, and CW interrogation of mitral valve on your lower right. Doppler interrogation from the right sternal border did not show adequate signals. The highest systolic velocity was obtained from the suprasternal border and was about 4 meters per second. The hemodynamics are summarized on this slide. The aortic valve area and index valve area were based on a left ventricular outflow tract dimension of 2 centimeters. So the question is what to do next. Should we repeat the echocardiogram after the blood pressure is controlled? Should we consider doing a dobutamine stress echo? Should we proceed with angioplasty, which is feasible? Should we proceed with replacement of the aortic valve percutaneously? Or should we proceed with surgical aortic valve placement with repeat bypass concomitantly? The effect of blood pressure on measurements of aortic stenosis has been investigated by our group. We show that elevation in blood pressure may result in a decrease in aortic valve area, meaning more severe aortic stenosis, largely in patients with a decrease in transvalvular flow. Thus, repeating the echo after the blood pressure is controlled is unlikely to be very useful in this case of severe aortic stenosis. The use of dobutamine stress echo is mainly to differentiate true from pseudo-severe AS in patients with low transvalvular gradient and low EF. This test is clearly not relevant in our patient with normal EF and high gradient. So what should we do then? I think our decision was to proceed with angioplasty and at the same time try to get better control of her blood pressure. Let's go over the reason why this decision is appropriate. Let's return to her echo images. You can see that although the aortic valve is sclerotic, it opens quite well. It would be unusual for this to create significant severe aortic stenosis. And if we examine the spectral Doppler again, and we can see that from the apical window, the transvalvular gradient is actually quite low with no significant stenosis, and this is in agreement with the 2D pictures. So the unusual aspect is the high velocity obtained from the suprasternal window. Now, what could account for that? The high velocity was due to stenosis of one of the arch vessels, which was later found to be a tightly stenotic left common carotid artery. And you can see the turbulent flow in the arch vessel on the left-hand side of your screen. This case underscored the important connection between structure and function. When the valve appears to open well, it would be inappropriate to believe that it is stenotic based on the Doppler signal by itself. A more common scenario actually is a highly sclerotic immobile aortic valve and low transvalvular velocity. In that case, it also would be inappropriate to conclude that this represents mild aortic stenosis without further testing. The other important point illustrated by this case is that CW Doppler is not range specific, meaning that it can pick up abnormal velocity along the whole path of the Doppler beam. This point needs to be kept in mind when you encounter unusual velocity signals using CW Doppler. This phenomenon can also be encountered when you are using pulse Doppler, although is a less common phenomenon. The common pitfalls in the assessment of valvular disease are summarized in my last slide. We need to be particularly obsessive when reviewing suboptimal studies. Do not accept measurements based on incomplete velocity envelopes. Multiple windows need to be used, particularly in the setting of eccentric flow jets. Non-imaging probes should be readily used in patients with aortic stenosis. There is a close connection between structure and function. When there is a discordance between structure and function, we should look at the reliability of the measurements, including proper positioning of the sample volume and unusual flow velocities along the entire CW Doppler beam. There are limitations of hemodynamic assumptions under specific conditions, but time does not allow me to cover them.